outset, I'd like to thank Dr. D'Souza and other members of the organizing committee for inviting me here and to be amongst you. So the topic that is being given to me is the vascular access in children and issues and challenges. Before we go ahead, dialysis itself, there's a big question mark and it's a challenge once you talk to the family. And before you even talk of dialysis, there's always a question of what type of therapy can be offered. And these are the factors in the study which affected the choice. One was the age of the child, parent choice, social condition, or unable to do one mode. And traditionally, in pediatrics, it's a strong PD-dependent program. And hemodialysis was always in the default mode, being reserved for children who would drop out from the PD program, their rare medical complications or psychosocial issues like. However, over the last decade or so, as you can see from this slide, there has been a tremendous increase on the number of patients or number of children who are opting for hemodialysis, whereas the peritoneal dialysis has declined to commensurate with the improvements on technology. So currently, you would see more patients on hemodialysis, as is evident from this slide, than on peritoneal dialysis. Now, starting hemodialysis in a child is a challenge in itself because one size does not fit all. You require different catheters, different dialyzers, different tubings, different blood flow rates, different drug doses, including heparin, and different dry weights at different times. Now, once you have overcome all this issue and you have decided that here is a child that you need to start dialysis, you are all set. You still may not be successful if your access is not there. So access is the Achilles heel as far as hemodialysis in children is concerned. So let's see what we understand by an ideal vascular access, and this could apply very well to both adults as well as children. It's an access which delivers a flow rate adequate for the dialysis prescription, has a long use life, and has a low rate of complications like infection, stenosis, thrombosis, aneurysm, and in pediatric vascular access, the performance is directly dependent on the blood flow. The access that gives you the best blood flow is the best access. And we require a minimum of 30 to 50 mils per minute to minimize access and filter clotting, a maximum rate of about 400 mils per 1.73 square meter, and these are different age-dependent rates in children. Obviously, in neonates and infants, we use much higher flow rates as compared to adolescents. These are the European Dialysis Working Group guidelines, which was published in Pediatric Nephrology. The guideline 4 deals with access. And again here, like in adults, AV fistula is the access of choice. Then you have got grafts, you have got catheters like Permacat, IJ femoral. And these catheters are available in infants of baby size. You need biocompatible membrane, and then there's always the child choice of sterilization. And obviously, you need to keep in your mind the amount of blood volume that is required as far as the extracorporeal circuit is. So the AV fistula is the preferred vascular access for children. In young children, less than 15 kgs, you need to keep in mind that some months would be there before the fistula matures. The same rule like about 6 weeks or 2 months does not hold true, so you have to be patient. The double needle technique is the standard, but occasionally in infants we have used single needle with double pump as an alternative. There is just not enough space in neonate for putting in a double lumen catheter, so even a single catheter or a single lumen catheter with clamps for small children is a acceptable compromise between a very low extracorporeal blood volume and valuable dilating. And this is the current NAPATEX data showing you the distribution of the different vascular access, and obviously because of the size issues, the vast majority of children currently in the US get dialysis into venous catheters, followed by AV fistulas at about 12.3%, and AV shunts are still being used in a small. So let's first take up the AV fistula, and AV fistula needs to be considered in all pediatric hemodialysis populations. And the AV fistula success rates can be improved through a multidisciplinary team approach involving the pediatric nephrologists, experienced HG nurses, vascular surgeons, interventional radiologists, and also recreational therapists or child health specialists. and the time to maturation, as I mentioned, maybe sometimes up to 6 months. So you use a non-dominant forearm, and the vessel size is perhaps the most important factor. And several studies have shown that as long as you have a minimum 2.5 millimeter venous diameter, you can hope for a reasonable success. The ultrasound scanning or venography can provide information regarding adequate vessel size, venous stenosis or occlusion, and should be considered in pediatric patients so that the best location for AV fistula can be determined. And again, surgeons have used intraoperative adjuncts like loops, microsutures, and the operating microscope. And increasingly now, microsurgical techniques are being used by surgeons to improve upon these success rates. This is the Fistula First initiative, which was launched in the US, and it's as relevant in our country and applies equally well to children as well as adults. The first and foremost is a timely referral to the nephrologist. Again, selection of surgeons based on performance outcomes and ability to provide access. AV fistula placement in patients with catheters when appropriate. AVF placement in patients with AV grafts when possible. Cannulation training is a must for AV fistulas. And education for patients and caregivers. And in our scenario, we have found it's equally important for the ICU physicians, because the commonest place or the graveyard of AV fistulas is the ICU. And once the AV fistula has been placed, and for some reason or the other, these children are admitted in the ICUs, you need to educate the nurses, you need to educate the ICU people that you have to take care of this access complications like stenosis, thrombosis, and leg length disparity in children also have been documented whenever AVF fistulas have been placed in the lower extremity, and Steele syndrome. And earlier on, you had an excellent talk by Ravi Bansal about how to diagnose and manage this. We next move on to AV grafts. They are very uncommon in our country, but it is an option for SG access, especially those who require the replacement of native vessels to perform an adequate anastomosis. And the materials that have been used are saphenous vein, bovine, umbilical, Dacron polyurethane. Cryopreserved femoral veins have been used, but the most popular and most practical is currently the polytetrafluoroethylene grafts. Because this has the lowest complication rates, and it's also easier to obtain and easier to repair. The ideal place is in the forearm between the brachial artery and the basilic or the brachial vein. Occasionally thighs have been used, the femoral artery and femoral or saphenous vein, especially in smaller children. Disadvantages include thrombosis, stenosis, infection, Steele syndrome. And graft removal is must, especially if infection occurs within weeks of placement or results in sepsis, because then that is a life-threatening issue. Just a quick comparison with fistulas versus grafts. Fistulas have very low infection rates, lower thrombosis rate, may take 3 to 6 months to mature as compared to AV grafts where you could be used within few weeks. The primary failure rate is higher as opposed to AV grafts, but secondary failure rates are lower, and obviously in us, in the Indian scenario, there are cost benefits also. Next, you move on to central venous catheters, and catheter may be the primary access in a child who has got either an acute kidney injury or who has chronic kidney disease but comes to you with an acute presentation, especially in small children or if they are going to be on for short period on hemodialysis. If you're anticipating a quick transplant, then I think the central venous catheters would be the way to go. The internal jugular access is far superior to subclavian vein because it preserves the future AV fistula implantation on the arm. Femoral catheter access is only for rescue or transient access. If intensive care is needed, it's easier to perform but has a higher risk of infection and thrombosis. And in neonates, we've also used the umbilical access for dialysis. But if you're planning for a chronic dialysis, then Permacath, a double lumen cuff catheter, which is at least 8 French in size, is the preferred rate. It gives preferred mode. The survival rates are anywhere between 30 to 85%. Pros and cons of CVCs. They're easily placed, but the infection rates are high. You can use them immediately, but the failure rates and replacement rates are high. They are painless to the patient. It's a very important issue, especially as far as compliance issues are there for long-term dialysis. no child would like to be poked twice a week or 3 times a week. But the blood flow rates are variable, leading to poor clearances. Again, it requires little planning prior to placement, whereas it could cause permanent damage to the central venous system, especially stenosis, thrombosis may occur. It can be easily removed if it's used as a transitional access for the future, especially if the child is going on to peritoneal dialysis or transplants. There is no vascular steel and there is a decreased risk of high output cardiac failure. Whereas with central catheters, there are these other advantages of possible. Again, what's an ideal catheter characteristic? First of all, it should be easy to insert. It should give you adequate blood flow without vessel damage, and then they should have the lowest recirculation rates. They should be less kinking, and then you have the short and large catheters. Again, the size does matter. You would try and use the larger catheters because of lower resistance and improved blood flows. So before you plan a central access, always match the catheter size to the patient size and the anatomical side. So again, that one size does not fit all. Again, you have one dual or triple lumen or 2 single lumen uncuffed catheters can be used. And the median survival times of central venous catheters have been reported anywhere between 4 months to 11 months. And this is enough for you to quickly move on this child transplant. What about this side? The current NKF DOKI guidelines recommend this order as far as the CBC placement is concerned. The right internal jugular is the preferred side, followed by the right external jugular. Then you have the left IJ and the left external jugular, subclavian femoral, and lastly, in very, very difficult cases, you could use translumbar access to IVC. And this order is based on the complication rates from the lowest to the highest. What about catheter position? Well, there is no right or wrong choice of placement, and the factors that would influence your decision would be a clinical expertise, the body habitus, other catheters, the citrate anticoagulated triple is preferred, coagulopathy, or if there is intra-abdominal. The IJ is certainly, the right IJ is preferred, and you should aim for the right atrium to secure your best blood flow rates. Subclavian, there are issues of patient mobility. This is most frequent site of inadequate performance. The catheter often curves and averts against the superior vena cava, leading to a venous collapse and due to position or volume change. And these issues are obviously magnified in children when the venous diameter is very small. The femoral vein you require an optimal positioning in the inferior vena cava. The kinking is the most common reason for central line removal in the uncuffed catheters, and the second most common reason in cuffed catheters. So always match the catheter size to the vein, and kinking can also be potentially prevented by bending the catheter in a C or U shape prior to tunneling the line. And this creates a contiguous arc in the catheter to avoid constriction of the lumen. And these are the different catheter sizes. You would use anywhere starting from a 5 French in a neonate to 7 French in 3 to 6 kgs, 8 French 6 to 30 kgs, to a standard 12.5 in a child who weighs more than 30 kgs. So this should be there in your dialysis unit as an SOP so that you are not called late at night, and all the catheters should be available also. Femoral remains one of the most common sites, and these are the pros and cons. It's a relatively large vessel, would allow for large catheters and higher flows, and the tendency of nephrologists to target good clearances. Your ease of placement can be done within minutes, no risk of pneumothorax, and again, you could preserve the potential of future vessels for chronic hemodialysis. But if you're using a very short femoral catheter, you are increasing the chance of recirculation. Again, if the child has ascites or has increased abdominal pressure, then the flows would be an issue. And there is a trauma to the venous anastomosis site for future transplant. In contrast, the IJ or the subclavians are definitely better. There is a tip placement in the right atrium which significantly lowers the recirculation. It is not affected by ascites. It preserves the potential vein needed for transplant. And with subclavian veins, this is now more or less given up. You have the issues of subclavian vein stenosis, the SVC syndrome, risk of pneumothorax, especially in patients who are on ventilator with very high PEEP, and there is trauma to the veins needed potentially for future hemodialysis access. So the IJ is the vein of choice as far as venous access is concerned. And this is another study which looked at the femoral versus IJ catheter performance, and I would like you to focus on the recirculation rate. So if you're using the shorter femoral catheter, especially less than 20 centimeters, the recirculation is as high as 26.3%, whereas with the larger catheters it's about 8.5% only, and the least is obviously with the jugular catheters, and it's for this reason again that these are the currently recommended catheters for central venous access in children. Complications, the most common reason for cup CBC removal in children remains infections, and these can range from exit site infections to tunnel infections to bacteremia, septic shock, bacterial endocarditis, and even osteomyelitis and epidural abscess have been reported. The sepsis rates with CBCs approximate anywhere between 80 per 100 patient years to as compared to only 10 per patient years for AV fistulas. So no wonder AV fistulas are still the best option. The infections can be decreased by the use of sterile techniques when they are being placed or replaced by washing again in between dialysis, and just not by changing gloves as is commonly done again, and by use of antibacterial or antiseptic solutions for exit care. And interestingly, in one study they found that use of 2% chlorhexidine gave you the best rates, only 0.5% infection rate as compared to even betadine or alcohol. So this is currently recommended for the asepsis in these patients. Again, no difference in the exit site infection rates between transparent dressings and dressings with higher transmissions of moisture vapor. Antibiotic catheter locks have been used to reduce central venous complication, central venous infection rates. And currently citrate is the ideal ACL lock solution. The access should, once it has been placed, should be assessed weekly by inspection, palpation and auscultation by the nursing staff and as well as by the nephrologist, with specific attention to the arm swelling, the prolonged bleeding after needle removal, or a change in the thrill of brewing. The nephrologist should also do that, and any difficulties in needle cannulation or decrease in the blood flow due to an elevated negative arterial pump pressure should be noted, and this should be the first sign of caution or a danger signal. But once our access is made, it's mandatory to monitor a good physical examination should be done on every dialysis, and this should include evaluation of the quality of the arterial pulse to assess for arterial occlusion and impairment of flow, particularly in patients who have got history of peripheral arterial lines. Prior to the venous AV fistula placement, venous elasticity should be assessed by measurement of venous caliber, and after venostasis is applied, venous length can be assessed by manual palpation of the vessel. Again, bedside duplex ultrasound is a great accessory to help you plan your access. You should keep an eye on the KT by V or urea reduction ratios, and determination of access circulation should be documented on a monthly basis. An adjunct should be used to determine blood flow to the access. The ultrasound dilution measurements, if it is available, are ideally recommended, but Doppler ultrasound is perhaps a very quick and practical way to monitor this. And once you get into issues, these children should be quickly referred for fistula cramp with possible angioplasty if there is inadequate blood flow, thereby compromising adequacy, elevated access recirculation more than 20%. If you have a corrected access flow which is less than 65 mils by the ultrasound dilution techniques, consistent abnormality on the Doppler ultrasound, or a pseudoaneurysm formation, and again a monthly review of the access should be conducted. If the AVF fails to show signs of maturation within the first 4 to 6 weeks, or it develops secondary failure and evaluation is required. If there is a deep location of the vein, then AVF may be patent, but it's inaccessible, then you require a surgical transposition to superficialize it. If the AVF has just been done within the last 4 weeks, then surgical option is preferred as compared to angioplasty, whereas if it's more than 4 weeks, then angiography or angioplasty is preferable. So towards the end, I would just quickly take you to the KDOKI guidelines for vascular access in pediatric patients. And to summarize, The choice of access, permanent access in the form of fistula or graft is the preferred form in pediatric access for maintenance dialysis. Circumstances in which a central venous catheter may be acceptable for pediatric chronic access include lack of local surgical expertise to place the permanent access in small children. If the patient size is too small to support a permanent vascular access, like less than 10 kgs, or there is an expectation of a very quick kidney transplant. If the surgical expertise is to place permanent access does not exist in the patient's pediatric setting, effort should be made to consult the vascular access expertise among the local adult-oriented surgeons to either supervise or place permanent vascular access in children. The program should evaluate the patient's expected waiting times on their local disease donor kidney transplant waiting list, is mainly for US, and serious consideration should be given for placing permanent vascular access in children more than 20 kg in size who are expected to wait for more than 1 year for a kidney transplant. After vascular access in place, stenosis surveillance should be done, and AVG stenosis surveillance protocol should be established to detect venous stenosis and direct patients for surgical revision, and same holds true for the AV fistula. Catheter sizes should be matched to patient sizes with the goal of minimizing intraluminal trauma and obstruction to blood flow while allowing sufficient blood flow for adequate hemodialysis. The external cuffed access should be placed in the IJ with distal tip in the right atrium, and a blood flow rate in the external access should be at least 3 to 5 mL per kg per minute, which is just adequate to deliver your prescribed hemodialysis dose. So I conclude by saying that vascular access in pediatric hemodialysis patient is challenging but not necessary undertaking for the nephrologist. It remains the Achilles heel, and advanced planning to assure that the best permanent placement is required. You require a multidisciplinary approach and ongoing monitoring to ensure its long lifespan. It's imperative to have a long-term vision to decrease morbidity, and we should try and minimize or totally avoid the prolonged use of central venous catheters because of the risk of infection and the need for vessel preservation. And the issue is not who places the access, but who does it right every time to everyone and everywhere. And these are some of the children that we have managed over the years. So I end on this note by an ancient Chinese medical text that superior doctors prevent the disease, mediocre doctors treat the disease before evident, and inferior doctors treat the full-blown disease. And by appropriate management of vascular access and appropriate vascular